All right. Well, welcome everyone. Just wanted to say on behalf of the Northwest Mental Health Technology Transfer Center, welcome to today's webinar, Cognitive Behavioral Therapies for Serious Mental Illness in High Security Settings. This is the third and final webinar in our three-part series on forensic mental health. We'll share where those live if you want to access those recordings later in the webinar. We're so grateful many of you could join us to learn more about this important topic. We look forward to sharing important tips and guidance and having an exchange of information with you. My name is Christina Clayton, and I'm one of the co-directors of the Northwest MHTTC. So first, a little introduction about the MHTTC network. The MHTTC network is a nationwide network that is supported by the Substance Abuse and Mental Health Services Administration, otherwise known as SAMHSA. It was funded in 2018, and the purpose includes disseminating and implementing evidence-based practices for mental health issues into the workforce. That includes supporting those evidence-based practices, heightening awareness, knowledge, and skills, fostering alliances, and providing and connecting you to free training and technical assistance. Now about our Northwest MHTTC. We're based at the University of Washington in the Department of Psychiatry and Behavioral Sciences, and we provide training in TA, humbly so, to our Region 10, which includes Alaska, Idaho, Oregon, and Washington. And I always like to say here, anyone from Alaska, we know that this map is not to scale, that Alaska is much bigger than this. Don't believe the maps. Our area of focus is evidence-based practices for serious mental health issues such as psychosis. So today is one of those examples of those topics. However, we do provide training on a variety of topics, including integrated care, suicide prevention, diversity and equity issues, school mental health, peer support, trauma-informed approaches, and others. And our target workforce is really broad. It's really anyone whose work has the potential to improve behavioral health outcomes for individuals. And how do we fulfill our mission? Well, we do live events like this webinar that we also record and post so you can watch them at your leisure. We do virtual learning communities. We have free self-paced online courses. We have newsletters that share a bunch of resources and announcement on events. And we have a resource library on our website. And so we do share other events from other training centers. And if you want to learn more, please go to our website and you can sign up for our newsletter. Just a land acknowledgement that's so important. Even though we're a regional center and most of you might not even be from Region 10, we're really honored and always want to acknowledge the cultures and lands across our region, especially spanning this very vast region. We want to acknowledge that we are based in Seattle and we sit on the traditional land of the Duwamish and Coast Salish peoples, past and present. And we honor with gratitude the land itself and the people who have stewarded this land throughout the generations until today and still today. We always want to be mindful of using language that promotes recovery and culturally appropriate terminology. So we just encourage folks to use language that demonstrates person-first language, dignity and worth. This is nothing new to folks, but it is something our network shares at every webinar because it's consistent with recovery-oriented practices. Now, a few logistics. Due to the large audience, it is a webinar. You're muted, you're not on video, but you do have access to chat, so that's really great to see. The presentation is being recorded, so the recording and the slides will be made available on our website in a couple of weeks. You'll receive an email to access a certificate of attendance. It's not formal CEUs, but they often can be used in lieu of those if you apply for your specific board. And you'll get an email about that. Using chat, please let us know, and our team will help with any tech issues. We are planning to have questions at the end, so if you have a question at any time, it doesn't interrupt anybody, just throw it in the Q&A box, and I'll be monitoring those and queuing those up for Dr. Kapelovich. We won't interrupt the flow of the presentation, and if you put them in the chat, I can't copy and paste it. It's just a little Zoom quirk. So if you do that, we'll ask you if you can please put it in the Q&A. And we'll do our best to answer as many questions as we can. And if we need to, provide a short written response or get back to you later. Lastly, your feedback is crucial to our work. And I will say our presenter today is very, very interested in your feedback because this is a new center, not new work for her though. And we really, as a center, look at your responses in a anonymous aggregated way. But we just take a very short survey that helps just tell us how it went today. What would you like to see more? What things really struck you as really helpful? We are required to provide SAMHSA this survey, but we really do appreciate your feedback for planning and to help keep free training coming. Obviously, SAMHSA sponsors this work, but doesn't have an official position on this content. Now, the important part. Today's presenter, we're very honored. This is someone who actually helped put this center together when it was in its infancy and application stage. So very, very excited to have her back in a core faculty role and sharing. She's a licensed clinical psychologist with specialized training in serious mental illness and forensic psychology. She's an assistant professor here in our Department of Psychiatry and Behavioral Sciences and serves as core faculty for the Center for Mental Health Policy and the Law, the Spirit Lab, and our Northwest MHTTC, as well as the Washington State Center of Excellence in Early Psychosis. Dr. Kapelovich specializes in evidence-based psychotherapeutic treatments for schizophrenia spectrum and other psychotic disorders. And at this point, I'm going to turn it over to Dr. Kapelovich. Thank you so much.
Thank you. I'm just going to get myself situated here so you all can see my slides and I can see you. Great. Hopefully you're able to see those now. So I appreciate thrilled that many of you were able to make it to this webinar today, and just so impressed by the diversity that I saw on the registration list in terms of the settings and the systems that you all are representing, as well as the roles. So we have students and trainees here today. We have folks in academic institutions, and I believe we have practitioners, if I'm not mistaken, across corrections, forensic, and behavioral health settings. So that is fabulous. And just to ensure everyone is aware, particularly if those of you who are accessing this web, the third topic in a three-part webinar series that's being co-sponsored by the Center for Mental Health Policy and the Law, as well as the Northwest Mental Health Technology Transfer Center. And you'll be able to access the recording of these slides on the Northwest MHTTC website. All right. Just seeing chats coming through and making sure it's nothing I need to attend to. Great. Okay, so Christina already gave you a little bit of information about me and where I'm coming from. I have worked in forensic, high security forensic settings. I have provided dialectical behavior therapy and cognitive behavior therapy and helped to create a proposal for a DBT unit in a maximum security forensic hospital. And I think for me, one of the reasons why this topic is really near and dear to my heart is that this is a population, individuals with a serious mental illness who are interfacing with the justice system, who are really mired in not just two systems, but really two worlds. I have worked in these settings across 4 different states in outpatient, inpatient, and forensic settings. And what I notice when I'm either delivering a cognitive behavioral intervention or when I'm training other practitioners to deliver these interventions is how these interventions can unlock the mind even when the individual is under lock and key. And so I'm really passionate about shifting from a custodial or traditions-based clinical approach to one that really conforms with our national and international care guidelines for a disenfranchised population. And I think we've really been mired in this debate for a couple of decades now about, do evidence-based treatments work or are they appropriate in these settings? And so I'm going to touch on that debate here today so that everybody's aware of it. And it's not to say that anything I say here in this next 40 minutes is going to necessarily put that debate to bed, but I think we can start to advance the conversation from what needs to happen for justice-involved individuals with serious mental illness to how to accomplish these changes at the individual and the systems level. So this webinar, this third webinar in the series, is really an attempt to disseminate some findings related to the treatment of individuals primarily with schizophrenia spectrum disorders. I try to be broad and inclusive in thinking about other serious mental illnesses like mood disorders, primarily with psychotic features. And it's intended to be relevant to administrators and practitioners. So that's why I'm so happy that we have representation from both and from across the different settings as well. So I hope to build a case for the utility of CBT or CBT-informed care in the first half of this webinar, and then provide some concrete empirically informed recommendations for how to foster greater access to CBT in these high security settings. I think that could probably be a whole other webinar though in and of itself. All right, so first, I just want to make sure that we have some agreement on the terminology that I'll be using throughout the webinar. High security contexts vary. So for our purposes, I'll be referring to high security healthcare facilities, and that typically will pertain to forensic units or hospitals, but it may also encompass mental health housing in correctional facilities. Okay. All of these settings are tasked with safeguarding the public, with promoting patient recovery, and they may additionally be tasked with addressing a specific psycholegal issue like competency restoration, for instance. And these settings are also unique in that the population represents highly clinically complex patients. So we see high rates of complex trauma, PTSD, traumatic brain injury. I'll be talking about some of these complications later. Broadly defined forensic populations or forensic patients are individuals with a mental health diagnosis who also have some involvement with the criminal justice system. Historically, forensic patient was used to describe a narrow class of individuals. So for instance, those found not guilty by reason of insanity, those found incompetent to stand trial. Adding to those traditional forensic commitments are inmates who are sentenced to correctional facilities who have a mental illness, individuals who are court mandated to treatment. And there's really been sort of recognition of the need to tailor psychiatric services to these special populations. And they also have expanded, this term has also been expanded to refer to individuals who are housed in psychiatric facilities by compulsory admission. So for instance, civil commitment. Right. So I think that social determinants of health have become a popular topic of discussion and are increasingly being recognized as a priority in terms of funding and policy and practitioner behavior. There has been this, I think, this just dearth of attention on how social determinants impact treatment referrals, treatment engagement, and treatment outcomes among those who are justice involved. So I would say that an individual with serious persistent mental illness, criminal justice involvement, and being an individual from an underrepresented cultural group represents a dangerous cocktail in terms of health and justice outcomes. And so it's critical that we're attuned to the intersectionality of these reference groups. These are relevant to the triple stigma that many of our clients face, as well as to their clinical and criminal justice outcomes. All right, so I am a CBT therapist and a CBT for psychosis trainer, as was mentioned earlier. And one of the core stylistic features of CBT is that we incorporate motivational strategies, which are really needed in order for people to be motivated to learn new information or engage in a new set of behaviors, particularly complex behaviors like changing clinical practice or fostering organizational change. And so my hope is that I've developed a presentation that's relevant to you, regardless of whether your role is administrative, clinical, or custodial, and regardless of your setting. So if you are an administrator or practitioner in a behavioral health setting, the webinar, I think, is relevant to you for a few reasons. One, we know that the rate of institutionalization in the US has increased 60% since 2000. Individuals with a serious mental illness are at least 3 times more likely to be treated in a mental health facility, or excuse me, in a forensic or correctional facility than in a mental health facility. So our patients that we're treating within behavioral health settings are at high risk for receiving at least episodic care, if not long-term hospitalization in a forensic or correctional setting. And then in addition to that, we are now managing behavioral health crises in short-term psychiatric facilities or community behavioral health settings that 50 or 60 years ago were being managed in long-term psychiatric care facilities. And the same is true, of course, for correctional facilities, which I'll talk about next. And so because of this, practitioners are expected to be able to identify and manage risky behaviors in the community. And in fact, Mullen, around 20 years ago, advised that risk management is considered a core competency in all of mental health practice. So our clients are really moving within and across these disparate systems. And I would argue that one of the best things that we can do for ourselves, for the systems, and for our patients is to look for opportunities to create synergies between them, to have a common language between them, to make transitions between systems less, I would say, deleterious at best, iatrogenic at worst, for our patients. All right, sorry, I'm having a glitch. Let me just get back up and running here. Okay, and hopefully my panelists can let me know if I'm not sharing. Okay, if you are an administrator or a practitioner in a forensic or correctional facility, it's important to be aware of the international and domestic guidance on psychological treatment of individuals in forensic and correctional settings. So the World Psychiatric Association's position statement on mental health and public health care guides us to ensure that mental health staff working in these facilities have knowledge, expertise, and clinical competence in assessment, diagnosis, and treatment of people with mental health disorders. The UN General Assembly states that healthcare provision should be as good as that available in the community and accessed free of charge. And then I'm really excited to share for the first time, this is a bit of a sneak peek because it's still pre-publication, but I worked with the Substance Abuse and Mental Health Services Administration with the Department of Health and Human Services on a guide for implementation, routine administration of cognitive behavioral therapy for psychosis as the standard of care. And in that report, we say, consistent with SAMHSA's no wrong door policy, CBT should be implemented within our mental health systems, and CBT for psychosis informed care at a minimum should be implemented in primary care, correctional and forensic settings, emphasis added, and educational settings. So this is the first time that a federal entity has made this kind of a statement about routine administration of cognitive behavioral therapy for psychosis wherever our individuals with psychotic disorders are coming for care. And then finally, my hope is that this webinar can help to fill a bit of a gap in the treatment research and implementation of CBT for forensic populations with a serious mental illness. There's been a lot more attention paid to CBT interventions for offending populations that are unaffected by psychosis, which has left most of us kind of wondering whether and how CBT for SMI or CBT for psychosis can be administered effectively. So just so folks are familiar with them, I've listed here the 6 most widely known cognitive behavioral programs for non-psychotic justice-involved individuals. There has been a call to adapt these empirically supported treatments, both for offender populations, which I just showed on the previous slide, as well as evidence-based treatments for individuals with psychosis, since in forensic or correctional settings since at least the mid-1990s in the US. And yet the research on administration within these settings, let alone trialing adaptations, is remarkably sparse. So the research suggests that we need interventions for this unique population for a few reasons. One is that this population is more likely to have neurocognitive deficits. And in addition, they're more likely to have impaired social cognition, which is often a presumption of CBT for offender populations, like moral recognition therapy, as well as metacognitive abilities, which is the ability to think critically about your thoughts. And then in addition, individuals with justice system involvement and psychotic disorders tend to have high rates of comorbidities, right? The individuals that we see, particularly in forensic hospitals, tend to be the most clinically complex population you will encounter, right? It's common to find comorbid personality disorders, substance use disorders. We find astoundingly high rates of trauma. So one of the most highly cited trauma and PTSD point prevalence studies among forensic patients found that almost 2/3, it was 2/3, 64%, I think, reported at least one traumatic event. And then we know that roughly 30% of those with the schizophrenia spectrum diagnosis also meet criteria for PTSD. And then finally, a history of traumatic brain injury is higher among people with psychosis than in the general population. In addition to that, individuals with psychosis experience a combination of attentional biases, information processing biases, reasoning biases that are unique to primary psychotic disorders, many of which have clear implications for their legal involvement. So, for example, their mental state at the time of the offense, which may factor into their legal defense or determination of not guilty by reason of insanity. Schizophrenia may increase the risk of violence. There's some controversy in the literature around the connection between schizophrenia diagnosis and violent behavior. So one of the most well-known studies to date it was conducted in 1998. It was a prospective study. So it started before individuals were discharged from the hospital, and then it followed them for, I think it was a year after they left the hospital, and they looked at rates of violence. This was almost 1,000 patients across 3 US cities. And they found that diagnosis of schizophrenia was a protective factor against violence. And then conversely, there was a systematic review and a meta-analysis that was published in 2009 by researchers at Oxford University, and it included 20 studies, more than 18,000 individuals across 11 different countries. These studies were, from the 1980s to the early 2000s, and they found quite a bit of variability in the risk of violence among individuals with psychosis. Overall, they found that schizophrenia and psychoses were associated with violent behavior. However, most of the excess risk from this group was mediated by substance use comorbidity. And that finding is consistent with the MacArthur study. So we know that the most significant risk is when an individual with psychosis is also using substances. So that's our sort of number one dynamic risk factor. And then in addition, certain psychotic symptoms will increase an individual's risk. So the nature of their voices, particularly command type hallucinations in the context of beliefs that the voices have power or protective value. And often when that's the case, we'll find that the individual will either act in ways that appease the voices or comply with the commands. And then with regard to delusions, there are specific delusions that seem to increase the risk of an individual engaging in violent behavior. So those include beliefs about being spied on, persecuted by others, that others are conspiring against them, and then a category of delusions called threat control override, or TCO delusions, in which the individual believes that other people are manipulating their thoughts or manipulating their behavior. And there's some research that suggests that TCO delusions may significantly increase the risk of aggression. Now, there is an important moderator here to these findings, and one that I don't think a lot of folks are aware of, and that is the emotional response to these experiences that can affect the degree or likelihood of violence. So the emotional response of anger, let's say to a TCO delusion, as opposed to fear, or as opposed to, let's say, acceptance. I know that this is part of my, this is what my mind sort of does when I'm stressed out or worried. That anger response increases the likelihood of violence among folks who are experiencing those symptoms. And that's really important because we're talking about CBT, which is really designed to help modify cognitive appraisals in order to change the emotional response and therefore the behavioral response. So all of these findings are critically important to making the case for routine administration of cognitive behavioral therapies for at least a couple of reasons. So first, CBT generally as a class of psychotherapy has been supported by around 1,000 randomized clinical trials and identified as an evidence-based treatment for more than 60 psychiatric disorders and problems of daily living. There is no other medical or psychological intervention that has proven itself to be more versatile than CBT, right? It is the most well-researched psychological intervention. What makes CBT particularly well-suited to high security settings is that it's considered an evidence-based intervention for problems that are common to forensic populations. So psychotic and attenuated psychotic symptoms, mood disorders and symptoms, co-occurring disorders, trauma and PTSD, medication-resistant symptoms, both mood and psychotic, personality diagnoses, violence and aggression, as well as offending behavior. And by violence and aggression, I'm referring to both to self and to others. And then in addition, adaptations have been made and studied for neurocognitive impairments, which I'll talk about towards the end, different cultural groups, and then different methods of administering CBT. So CBT, so you knew you weren't going to get out of this webinar on CBT without at least one cognitive triangle. But I think it'll illustrate this point about the case for cognitive behavioral therapies for this unique population. So CBT, we know, targets the way that people are thinking about their experiences, right? Those automatic interpretations we have. In some cases, we might be able to help the person identify where these explanations came from. If we're doing formulation-based CBT, we're going to look at core beliefs and how modifying these automatic interpretations can affect their own distress level. And in the case of folks with legal involvement, how modifying these patterns of thinking and behaving can help them achieve their goals, staying out of jail, right? Staying out of hospital. So let's briefly just talk through two examples. We'll start with a generic example of an individual in a correctional facility who hears voices and has a history of assaultive behavior. And this individual also has a past history of physical trauma, and he has developed a set of core beliefs that we often see among survivors of physical trauma. So, for instance, he sees himself as weak, as powerless, as a victim. He sees others as powerful and out to harm him, which makes sense given his history. And he sees his future as characterized by pain and suffering. When this individual hears a voice commanding him to assault the correctional officer who's approaching his cell, based on this combination of factors that includes his core belief, his state anxiety, past learning about, how he's come to see the voices as serving a protective role for him, he makes the automatic interpretation, the voices are trying to protect me. I better do what they say to stay safe. And the consequences of this interpretation were his compliance with the voices. So in this case, assaulting the CO, and this emotional cocktail of calm and vindication, right? I stayed safe because I listened to the voices, and also shame. Because he feels this vindication and calm following this act, he's more likely to maintain his belief that the voices are serving a protective function, and therefore more likely to comply with the voices in the future, which will come out in all sorts of ways, right? Some of which are impossible for us to predict because we're not able to hear what he is. So now let's talk about a specific forensic client. This is Matthias. Matthias is a pseudonym for a 49-year-old patient with whom I worked in a maximum security forensic admissions unit. And he was referred for competency to stand trial restoration. He carried a longstanding diagnosis of schizophrenia, and he was presenting at the time of his admission with formal thought disorder, voices, and bizarre somatic complaints. So he complained that parasites were eating him from the inside out, and that there's a good deal of paranoia towards staff, that the staff were infesting his room and his internal organs with these parasites. And he cited these somatic complaints as the reason why he wasn't able to attend interviews, wouldn't leave the unit. He actually didn't have permission to leave the unit, but wouldn't adhere to the unit routine. And he was disruptive. He was going to groups, but he was incredibly disruptive during the groups. So, and the other thing that was important to know about Matthias is that he had a history of assaultive behavior, and he was a big guy. And within the first 2 weeks of his admission, he had made assaults to staff on 3 occasions. So we met together for some initial sessions, and Matthias was incredibly scared. Oftentimes we see with somatic delusions that there is this underlying concern that other people, that you are vulnerable to harm and to illness, that other people have the ability to harm you and mean you harm. And so he was very, very scared all the time, and staff were scared too, understandably so. And so there was this, right from the get-go, this show of force every time they interacted with Matthias. And it was really actually triggering psychotic and impulsive type aggression. And so we were able to develop some shared goals. Everybody could agree that we all wanted to stay safe. Matthias from the parasites and other kinds of harms, and the staff from physical harm. And Matthias wanted to return home. And so we were able to transition those goals into some action steps. And that was a behavior plan that included the staff, and it included Matthias. Everybody had a role to play. And so we made a lot of adjustments to the nature of the interactions, the expectations for his participation. And he eventually not only started taking medications, but he was compliant with the competency restoration program on the unit, and was restored and sent back to the courts. Now, this approach, so this was an example, Matthias was an example of how CBT work preceded the competency restoration work, but then it also, throughout the 4 or 5 months he was there, was working in tandem to continue to address the somatic concerns, the paranoia, and to a lesser extent, the disorganization. We use some anxiety management strategies for the disorganization. And so these were really complementary approaches that both were in service of his recovery as well as to the psycholegal issue. But there was a paper that came out actually while I was working in that hospital, as a matter of fact, from one of the administrators of the hospital system. And it talks about this idea of the forensic paradox, in which safety and therapeutics are really seen as these sort of not necessarily mutually exclusive aims, but paradoxical aims, right? And so the public health and institutional safety in these high security settings, the argument is have to trump functional or symptomatic recovery, and focusing on recovery can even prolong the individual's stay in these high security settings. And so I think that that's sort of, that is an understandable perspective. On the other hand, I would argue that they're in fact serving the same aims of hastening the return of the individual to a lesser restrictive environment. So what is that? What are the implications here? These forensic mental health settings are high cost, low volume, and high risk. And so we have to be using interventions that are going to be high yield and high value for both health outcomes and criminal justice outcomes. And so let's talk a little bit about how CBT fits that bill. We already discussed the fact that it's applicable to diverse challenges that are common to individuals with serious mental illness in high security settings. In addition, CBT is amenable to diverse modes of delivery. And in fact, this proliferation of the diverse modes of delivery has, I would say, has radically democratized CBT. We have self-help or guided self-help CBT. We all know, those of us who are practitioners, within the last 14 months, we've got telehealth, telephonic delivery. We have digital CBT interventions through smartphone applications, internet, and now artificial intelligence-based CBT, group CBT, low intensity and symptom-specific protocols. So, this diversification of how we're administering CBT has translated to new opportunities for training a range of healthcare and allied professionals, including correctional officers. Although I think we really need to be careful about dual roles, and I think we need to be careful about too much task sharing or task shifting, as well as non-professionals, including peers, and I'm doing a lot of training of family members these days. CBT also emphasizes self-agency in identifying and solving problems. And so that is critically important to be able to enhance that sense of self-efficacy and mastery for an individual in a high security restrictive setting. And I think it's helpful for our folks in these settings to be present focused, because there's a tremendous amount of trauma and shame. And if the intention is that this is a short-term stay with resolution so that they can progress to the next thing, we want to stay really present focused and solutions oriented. It is consistent with the recovery model, and there's lots written on that, including in that SAMHSA guide that will be coming out in the next month or two. And then it also targets issues that are relevant to the legal issue, to an individual's psychological health, as well as safety. So I think CBT is consistent with, it's actually a central instrument for the risk-need responsivity model. If you're not familiar, this is an empirically supported model that is arguably the most influential model for the assessment and treatment of offenders. The risk principle guides us to match the level of service to the offender's risk to reoffend. The need principle guides us to assess criminogenic needs and target them in treatment. And then the responsivity principle is about maximizing the offender's ability to learn from a rehabilitative intervention. So I'm going to talk a little bit about how we're accomplishing these aims through CBT. And through adoption of a model of care that I've proposed for other, has been proposed, widely for in healthcare settings that I've applied to CBT for psychosis. Okay, so we know that CBT for psychosis has an established empirical track record in aiding recovery of non-forensic populations with psychosis. It's also been identified through comprehensive lit reviews as an active component of treatment in high security contexts. So Slater and Townend did a systematic review. The one thing to note, so it covered 14 studies. All of these studies took place in the United Kingdom. There were different modalities employed, individual, group, different target populations. They looked at a range of primary and secondary outcomes, although I will say most were focused on psychotic symptoms and not, and in fact, none of them were focused on psycholegal outcomes. And then, but I think, so, and they were published and unpublished, but I think one of the things that's important to note and be totally upfront about is that these studies had very small samples. They ranged from 1, so we had case studies, to, I want to say the highest was maybe 28 or 36, somewhere in that range. So not really meeting that bar of a randomized clinical trial that we're hoping to see. One of the things that we can take away is just the diversity in the modalities that were used. And we tended to see sessions between 10 and 70, but longer treatment duration overall, versus correctional settings. Cognitive behavioral therapies in correctional settings has tended to consist of this highly structured treatment, protocolized treatment that are delivered to groups in 8 to 12 people in classroom-like settings, and it's just not easy to scale individual CBT in these in the prison system in particular. Okay. So I'm running out of time here, so I'm going to hop over. I was going to just feature a couple of CBT-based interventions that have been implemented and trialed in forensic settings, metacognitive training, as well as STARE, which is Service for Treatment and Abatement of Interpersonal Risk. But I'm happy to answer questions about those or send out information about those treatment protocols after the webinar. So I really want to talk about some recommended strategies for delivering the intervention. So we have limited resources. We need to make sure that we've got some guidance about what's going to be most effective and for whom. So first step in any good treatment protocol is a comprehensive assessment. Depending on the context, this may include a psychological battery, cognitive screeners, a malingering screener, and perhaps the cultural formulation interview. And then we're going to proceed with our assessment based on as indicated by the screeners. And that's really, this assessment process is important because that's going to guide our selection of the interventions, as well as, in addition to the psycholegal, issues. So court-ordered competency restorations means we're going to be quite limited in our targets. We're only targeting the psychotic or mood symptoms that are impacting their competency or their ability to participate in the restoration programming. We want to clarify the psycholegal questions and professional roles. One of the points of opposition that I commonly hear about practitioners in these settings providing treatment is that it potentially puts them in a dual role. So we absolutely want to be attentive to that. We absolutely want to be limiting the possibility of dual roles. I've seen this done beautifully in the forensic hospital where I worked. We had our evaluation team and they were able to access the chart. We were very clear on the fact that we could not, there was no confidentiality in this setting, that this was, discoverable by the courts or by the evaluators. But, I know other settings don't have the luxury of having the evaluators be different from the treatment providers or the folks who are on the units. And then critically important is identifying shared goals between the patient, the treatment team, the institution, and the court. And I think that the example of Matthias demonstrates the importance of this in just terms of getting everybody on the same page. Okay, and then it's critically important that we're providing trauma-informed and culturally responsive CBT. I have two citations here. These are both book chapters and a book that I'll share with you at the end that really talk about some practical strategies for ensuring that our work is trauma-informed and culturally relevant. And then emphasizing strengths, resources, positive attributes, values, and goals. And when I say that, of course, I'm referring to the patient, but I'm also referring to the institution. So how do we mobilize the institution to engage in cognitive behavioral therapies and to really see this as something that's self-serving, is that we want to capitalize on the resource and the value system of these institutions. And so we know that we do this in cognitive behavioral therapy service delivery. We talk about these in terms of protective factors. We use these for motivational enhancement. It's also consistent with the Good Lives model, which is a strengths-based theory of rehabilitation for individuals within the criminal justice system. Okay, so the corollary to the risk-need responsivity model in the healthcare system, I would argue, is stepped care. So stepped care is a process of administering interventions such that the least intensive, efficacious dose of an intervention is administered to an individual, and then interventions are titrated up as indicated by their degree of distress or disability. And it's just an incredibly intuitive treatment delivery model. It's really intended to maximize the availability of treatment to patients while also conserving limited resources, which is the name of the game in forensic and correctional settings. And I've been doing this for the past 3-4 years with CBT for psychosis. And there's a paper that's referenced here that explains the conceptual model. And what I've done on this slide is translate that to what this might look like in a forensic setting. So I would recommend in forensic context, thinking about offering a range of interventions. Everybody's going to get milieu-based CBT, right? So that's sort of our foundation. We think everybody is likely to benefit from those interventions. And to enable that, we need floor staff, correctional and technical, to foster a skills culture, to reinforce CBT principles, reinforce psychoeducation, and help model and shape skills. And then you can see along the right-hand side, that arrow is another opportunity to reinforce learning, which is critically important for our folks with neurocognitive deficits or acute psychosis. We need to give them a lot of opportunities to practice these skills in person. And so in addition to floor staff, we could have mobile staff, mobile interventionists. We can also use CBT peer mentors who can coach their peers in the use of these skills. Next up from there, we're reaching fewer clients. Now we're relying on clinical staff who would be trained in CBT protocols. So we could have CBT for command auditory hallucinations, group CBTP, as well as formulation-based CBT. And that would be conserved for the folks who are most severely symptomatic or whose symptoms are most impairing their progression through the legal system or through to a lesser restrictive environment. And so again, all of this is to accomplish a few goals, right? We're diversifying the offerings and the service providers that we're using. And so we're effectively getting CBT into the water of the institution. So it goes from being seen as this standalone intervention to the therapeutic modus operandi, right? Second is that it really helps to ensure that we can provide cognitive, behavioral, motivational, and educational interventions to everyone, even if they're not amenable to a formal treatment course, even if they don't agree with their diagnosis. And then finally, when it becomes the dominant, when CBT becomes the dominant language across the setting, it provides the kind of repeated opportunities for learning that are needed for our folks with severe symptoms or cognitive impairment. I know I'm running out of time here. Make sure it's not a standalone intervention. The formulation really needs to be included in team meetings and in treatment planning. We need to ensure that our services are appropriate for everyone. So for our folks with cognitive impairment and thought disorder, small but frequent doses, repeated exposure, vocabulary and concepts are simplified. And if you want to learn more about adapting CBT for psychosis for this population with these kinds of impairments, I have a brief mini training on this topic, along with an assessment that I've adapted based on the literature to see whether an individual would be likely to benefit from CBT for psychosis. Okay, I'm going to end by just sharing a couple of resources with everybody. And so one, the two books on the right, these are texts that I'd recommend. New Frontiers in Offender Treatment, which is edited by Drs. Elizabeth Jeglick and Cynthia Calkins. And this goes into greater detail on adaptations to treatment in correctional settings, therapeutic alliance, burnout, vicarious traumatization of the clinicians. And then Forensic CBT is another fabulous text for clinicians that should probably be a required reading. The one thing to note is that there's not a strong focus on SMI populations. And then for those who are interested in learning more about CBT for psychosis, at the top left, there are some really fabulous, these are self-help books actually, which you could photocopy and use with clients. On voices and paranoia. The cognitive therapy for schizophrenia is that kind of our Bible for CBT for psychosis, and then a group protocol that I've been using in Washington State. And then we have the Northwest MHTTC. We have the Cognitive Behavioral Therapy for Psychosis e-primer, which I developed to just provide some foundational information about what a traditional treatment course of CBT for psychosis might look like and how it is similar to or different from other CBT approaches. And that is also available on the MHTTC website. So that is all I have. I hope I've left plenty of time for some discussion. I'll go ahead and stop sharing.
Thank you. Well, no, and while you're speaking, I put up a number of pages that you've contributed to so far in our tenure as a center. So lots of resources, whether they're archived webinars, many on these topics, online course that you talked about, and the research and practice briefs that also are very relevant, including cultural adaptation. So we do have a few questions. So I'm going to, some of these are deep and some of them maybe are a little more precise. So one is just a thank you for your presentation. Wonder if we're still missing something. Is there something more to understand about innate mental health? If CBT is currently the gold standard and has been, why is there still such an increase of people, reporting a lack of well-being? But to me, it sounds like it's the gold standard, but is not used all the places it could be. So that's the dilemma. But yeah, I don't know if you want to comment on that, just sort of how to get more in the field. And then we do have two more after that.
Yeah, no, I think that's accurate and an understatement at the same time. So for our population of folks with psychotic disorders, I just completed, it's under review right now, a point prevalence study on the availability of CBT for psychosis trained practitioners in the United States and Canada. And I will, 0.59% is the figure. That is the number, the percent of our practitioners across these two countries, licensed practitioners who are trained in CBT for psychosis. So it is, that would be a caseload of at least 10,000, 11,000 people for each one who's trained. So for that, for individuals with psychotic disorder, it is inaccessible. I mean, and then when we look at other disorders too, I mean, OCD, the average duration between the time an individual OCD onsets and the time that they first get psychological help or psychiatric help of any kind is 17 years. So it's not that we don't have treatments that are effective. In many cases, they're highly effective. It's an issue of we don't have enough practitioners who are using these interventions as they're designed to be used. We have, anyway, I'll just leave it at that. And two, the farther away we get from the lab, right? The farther we get from, what this looks like in a randomized clinical trial, the lower the effect sizes tend to be. And so what that says is two things. It's a training issue. It's a workforce capacity issue of like, how do we give practitioners the time to do good work, the time to learn these interventions? And then potentially it's also a generalizability issue, right? There are unique challenges that our folks in the real world are facing that somebody who can participate in an RCT is not facing. And so how do we adapt these interventions to the population and the settings that need them?
Yeah, no, that's great. So another question is, you brought this up in some of your slides. How do you deal with malingering related issues? Also for folks with TBI, how effective is this approach? So a couple parts to that question. But
yeah, so it's a really important question because this is obviously, even if we have the ideal scenario where in my mind, what's ideal would be we have stepped care, right, in a forensic context. So everybody's getting at least a little bit of something. People who needed it the most are getting a lot. there's still limited resources. And so when we are providing treatment to individuals who are malingering their symptoms, it's not a good use of resources, and potentially we're doing even more harm because this person is getting education about psychosis, which enables them to malinger more effectively. And so we have, I think that's why I said in the beginning, when we're doing our assessment, we need to be screening and then, if indicated, assessing for malingering. We have some good measures for malingering assessment. It doesn't mean we're going to catch everybody. And I think in delusion, with individuals who experience delusions, it's very, very difficult to parse out whether an individual is deluded, malingering, whether this is sort of, factitious disorder. There's a lot to unpack there that can be very difficult with the constraints that we have in these settings.
Yeah, I was going to say there are a couple that are related, because as a third question, just want to get to the intellectual issues. Of course, lots of questions coming in more now, but for folks with cognitive impairment due to whatever, how well do these methods work? I know you talked about adapting in different settings or in different, sort of, to me, it's like motivational interviewing. There's the real hard skills, and then there's a spirit of it. And you may not be able to do it in a lab setting with 50-minute hours and homework that always works. But how does it work when folks are having cognitive, not just maybe psychosis, but other cognitive impairments?
I think that is probably the set of challenges that is least focused on when you are learning CBT for psychosis protocols, even though it affects so many of our clients. So there's the mini training that I will send the YouTube link to that I did for my CBTP trainees in Washington. It's an assessment to determine whether the individual can make the link between a situation, an interpretation of that situation, and then the emotional and behavioral consequences. And that's the minimum bar. So if an individual is not able to make that link working forwards and backwards, then they're probably not going to be able to benefit from the treatment. And so then you're going to kind of need to use some other protocols.
So we do have a number of questions, and I know we're running low on time. Is there, I think what we'll try to do is maybe capture some of these questions and maybe ask you or your team, see if there's even a couple of short answers, a couple of references you've been mentioning. People are bringing up great questions about CBT towards medication adherence, the institutional culture, and shifting that to very specific, how do you deal with confidentiality when doing case formulation or presentation, and patients are hesitant to share knowing you're going to write this down. And then also, what you mentioned about practitioner training, what else is getting in the way? And to me, it seems like funding and priorities and lots of other things that are facing the workforce.
Well, and also I just want to add to that, because that's what I want to do next. Like that, I want a panel or symposium or, at worst another webinar at least, just to have that conversation, because there's so much that's happening within the last 5 years around taking what we're learning from implementation science for other settings and applying it within these settings. That's just untapped virtually.
Yeah, and it takes, just to answer Lauren's question, I mean, we don't have time to get into it now, but you've done a very intensive project on CBT for psychosis, but it was a huge effort, and it was funding for you, funding for all this people around the state that you trained in, and ongoing training and commitment, and so it's a lot of issues that come into play. And is there a commitment from the top and all around?
Absolutely. So I just want to say one quick thing, which is that the SAMHSA guide that's coming out on CBT for psychosis talks about all of these issues, right? It talks about the inner contextual issues that need to be in play for good implementation to occur, and the outer contextual factors that need to be considered, and how to get that organizational systems change.
Great. And I know the center that just launched, maybe you'll have a resource library at some point, or maybe you do already, but I think some of these issues might have some resources there too, if not now, then soon. Well, I just want to say thank you so much. Let me just share a little bit of a couple closing slides since we are out of time. We've done what questions we could do. Here we go. Your feedback, you've seen the REDCap link. It's very, very helpful for us to hear, not just in the chat, but in this survey that is confidential confidential. We don't know who's done what, but we do look at all your feedback. If you want to connect with us and hear about these kind of events and resources as they get promoted and provided, please let us know and be in touch with us. And this series will have all of the recordings up as well as related resources soon. And after that, I just want to say thank you to Dr. Kapelovich. It's been fantastic. And thank you so much for all your time. Lots of interest, clearly. And I think just a kudos to you that I know this is just a passion for you. And that really shows because there's just a lot of need and we need to treat folks with as much care as we can. So I appreciate it. Any closing thoughts from you?
I appreciate the opportunity to get on my soapbox.
Yeah, it's a good soapbox to be on. So, all right. Thanks everyone for joining us. We'll see you next time. Bye.